You.
So good evening. Thank you, Craig, for a very kind introduction. You're too kind. I wish I could be in Greece now, but unfortunately, this time I was not able to come. I don't know whether you see my slides.
Fantastic, but can you just put them full screen? Perfect. Now we see them full screen. Everything is looking good.
So I was asked to talk about surgical therapies for aortic valve. And as you probably know, you're all experts, aortic valve disease is one of the most straightforward and simple cardiovascular diseases. But unfortunately, it has become a controversial issue because there is somehow a clash between whether one should do a surgical therapy or transcatheter treatment, which is actually not really should be any discussion about that, because you have to consider both therapies as a tool in the toolbox. These are my disclosures. Medicine is a science of uncertainty and an art of probability. And this is important with regard to the aortic valve treatment, because unfortunately, even though we have many studies, randomized controlled trials, there are so many opinions and assumptions. But even evidence and the results of randomized controlled trials being discussed in the surgical community differently than in cardiology community. What is important to emphasize, if you consider randomized controlled trials being a holy grail of evidence, that only 10 or 20% of treatments that we give in medicine in general are based on randomized controlled trials. And if we go back to the original randomized controlled trial, only 6% of the patients that we on a daily basis would be eligible for those randomized controlled trials that dictate a specific treatment. Additional to that, this is a very interesting study published in JAMA 5 years ago, and gives a comprehensive overview of all the randomized controlled trials published in the field of invasive cardiovascular interventions. There are many things to discuss about this study, but one thing is interesting, which is called fragility index, which is the number of patients needed to switch the significance of any randomized controlled trial in the last 10 years from positive to negative. And this, the number of patients is only, the median number of patients is only 5 patients. So science and technological advances are quickly surpassed by time. And obviously, what we do in the field of intervention is also subjected to technology, and technology influence what we do. And I think TAVR or TAVI should really be considered as a disruptive innovation. It's an important innovation, and I think it's an innovation that many patients benefit from and will benefit, and it has really changed the field. So the field of cardiac surgery or cardiovascular intervention, unfortunately, we see that separate from interventional cardiology. But I think we should see that at one. And it has been always focused to try to reduce the surgical trauma, the intervention trauma. Obviously, by reducing the need of use of heart-lung machine, but also reducing the size of incision. And also, the minimal invasive cardiac surgery is also started with treatment of aortic disease that we have been conventionally using in a full stenotomy But nowadays we can approach it through the partial sternotomy or even thoracoscopic approach. One of the first established minimal invasive approaches has been actually for replacement of aortic valve through the partial sternotomy with peripheral cannulation in the groin. And additional to that, although the transcatheter valve therapy in many countries is an area that is for mostly intervention cardiologists are involved in many countries it is a joint venture. In Netherlands, for example, we have the same team involved in treatment of transcatheter valve therapies, whether TAVI or for mitral. And it's important because if you just look for the mitral valve, there are more than 70 different devices being developed, and the field will develop further. It is also important to just give an idea about the timeline of a conception of an idea and implementation and being in the clinical practice. And obviously, AVR or aortic valve disease, one of the most straightforward diseases that has been, you have a transcatheter therapy and option for. Even that has been something that has took a long time to be established in the clinical practice. And with regard to the mitral valve, this is something that will still, I think, take at least another 10 years. I think that you know the numbers that we have a significant increase in treatment of aortic valve disease with transcatheter option. But there is also a new surgical field that has been developed, which we call endoscopic approach or thoracoscopic approach. I think most of you know that from mitral valve, but there is also an option for aortic valve. And what is new about this technique is the incision can be as small as this incision around the nipple, and when the wound heals, you wouldn't even see any scar. And through this incision, we can nowadays do a replacement of aortic valve, mitral valve repair, mitral valve plus tricuspid with additional AF ablation. And you would be surprised because, how is it possible to do an operation through this kind of a small incision? Because this small incision is just an access for the instrument, because you will operate by being immersed with a surgical field in a 3D vision in the OR. So it is almost like you are inside the heart of a patient when you operate. And these patients, you don't need any retractor. There is a 3D camera, and this kind of operations nowadays we do it with extensive procedural planning, like a 3D reconstruction and simulation, to really select the right treatment for the right patient, but also plan the operation into the details that we have the highest efficacy and safety for the patient. And just give you an idea, this is one of my patients. This image. This is 2D, but normally in the operating theater, I see this image in 3D, full 3D in 4K, and you are immersed with operative view, so you can see all the details that even you cannot see during a median sternotomy. So one of the issues that I think very important, because with increased use of TAVI, bicuspid aortic valve. And as you know, this is a congenital anomaly to 1.3% of general population. And why is it important? Because 50% of patients under 70 years old with aortic valve stenosis have some kind of bicuspid pathology. And why is that important? Because bicuspid pathology is very heterogeneous. This is the Sievers classification. And why is that important? Obviously, there are many challenges. I'm not going to go through this because there are a lot of experts in the room with expertise on transcatheter AVR. We can discuss that. But it has been established that the outcome for transcatheter therapies in aortic valve or bicuspid is not the same as a tricuspid valve. And because these patients are young, we should be mindful to send them for TAVI. And this is a study of my group. It is a comprehensive analysis of all the randomized controlled trials using Bayesian statistics, showing actually that at 5 years, based on all the available evidence, you cannot say with 100% that TAVI is non-inferior to SAVO. And that is important if you consider that 50% of patients younger than 50 years of age have a bicuspid valve pathology. It is important to also be name the elephant in the room, because there are conflict of interest. Even those who say, I don't have any conflict of interest, they have conflict of interest. Being a patient, being a cardiologist, being a surgeon, we have our desires, our expertise, and there are many drives that patient-driven reasons, physician that force us to do a treatment. And I think if you put a patient in the middle and work together, free of conflict of interest, at least conflict interest being a patient, we can improve outcome. And by improving outcome, you will increase your volume, and by that, your practice. So what is the best practice? Look, this is the different spectrum of aortic valve pathologies. So they are not the same. So we need to consider that we have to individualize patient treatment, but also keeping in mind that everything in the field of surgery and intervention is also there is a factor of individual surgeon or operator or cardiologist with expertise or non-expertise. So volume and outcome, there's a strong association. So obviously there are cardiologists that they are able to do fantastic stuff with even in bicuspid valve, but as a group it is not reproducible. So we need to consider that expertise matter. How we have set up the treatment of valvular disease in Maastricht is focusing on lifetime management of the disease with the same team, coming together, all comers, using advanced technology, and to actually do our treatment based on precision intervention, which is considering the individual anatomy of the patient, clinical condition of the patient, but also our individual expertise, because we cannot do everything. We have to consider that we can be an expert on our pathology, but we have to work with colleagues with different skill set to be able to address many patients that we see on a daily basis. And very shortly about precision intervention is what is going to be very important in the future, virtual simulation, to really see whether if you place a TAVI in this patient, is there more increased chance of complications, digital twin, which using big data to see whether the treatment that we're providing a patient is also the best treatment, because there is a difference between somebody who is 80 and somebody is 70, but also there is a big difference between a patient without comorbidity and comorbidity. And lastly, using simulation to train teams, because even if you do what is the best treatment, how to provide that to the patient with a surgical or transcatheter, you still need skilled operators to be able to provide that. And this is my last slide, just an idea that the field is moving fast forward. So this is 2020, so and ever since there are many studies and even models and programs have been developed for clinical practice to simulate the treatment that we give to the patient, but also whether that leads to any complication. So future is bright for cardiovascular medicine and surgery, and I think important is working together to treat patients and consider interventions as a tool in a toolbox. Thank you so much for being with me. Thank you.
Fantastic, fantastic talk. Thank you very much. An expert, as always, mixed in with a little bit of science, a little bit of data, a little bit of philosophy, some nice surgical videos. So thank you for showing us your technique of endoscopic aortic valve replacement. My question is, which patients do you foresee staying with surgery? You mentioned the bicuspid patients. You know, I can think of endocarditis and a couple of other cases. What do you think the landscape will be like for surgery in 5 or 10 years? And can you please, the second part of the question is, tell us a little bit about what do you think is going to happen down the road with surgeons who are going to be faced with having to explant a failed TAVI when we can't do a TAVI in TAVI? And what is done with this at your center?
So with regard to the what will happen in the future is really dependent where you are. If we consider Netherlands, it is very strictly regulated, and even at this moment, we cannot do a TAVI in every patient. So you need, the government has set some criteria that we need to really go through in the heart team to see whether a patient is suitable or we can do a TAVI. But I think the first step is going to the age limitation of patients undergoing TAVI. And this is going to decrease gradually from 75 to 65. But I think there is going to be a lot of complications, a lot of problems occurring when you decrease the age to 65, 60, because a lot of these patients have a bicuspid pathology, and as you know, Craig, if you open these patients, they have a bulky calcifications. Even surgically is very difficult to get this valve out, and you can imagine, and there's a lot of data on how a prosthesis, a TAVI prosthesis will sit there, is going to, the durability is not going to be the same, and at some point we are going to see an increase of patients that are going to need an explantation of a TAVI procedure, which is a much difficult procedure than a conventional, obviously, AVR.
Thank you very much. We really appreciate your participation. I think now we have to move on to our next speaker, which is